I'd like to open this session on behalf of all of our presenters today by acknowledging the traditional custodians from the lands on which we meet and pay respect to elders past and present. Sovereignty has never been ceded. Now, the format today will be 3 short presentations followed by a panel discussion, and we're going to hold all questions until the end. But please, if as you're listening you have a question, pop it in the conference app. Normally, presenters love it when you keep your phone away. I want you all to have your phone out. I want you to open the session in the program on the app and ask your questions that way. We are recording this session, so that will ensure I can repeat your question back and we get good audio off it. So that is how we're taking questions. So please use the app. I also need to let you know that you will be receiving a certificate of attendance for this Congress, and all of the slides will be made available to you within the week. And if you could pop your phones on silent, but again not off because we need you to use the app, that would be great. All right, well, we will make a start, and first off the bat is myself. So hello there, I'm Jonathan Meddings, Chair of the Darbon Institute and author of The Final Cut, The Truth About Circumcision, and I'm here today to talk to you about the impact of circumcision on penile sensitivity and sexual function. But to understand that, we first need to understand the functions of the foreskin that are lost by circumcision when it's removed. There are many, and these are just some of them. Sensitivity is perhaps the most obvious. The foreskin is highly erogenous tissue. It contains an abundance of specialised fine touch receptors and other corpuscular receptors that together have a quite dynamic sensation when they're all firing. The foreskin also offers physical protection. The outer foreskin protects the inner foreskin and the head of the penis from chafing and infection, and it also provides adequate skin coverage, which is why the removal of too much of the foreskin by circumcision can result in painful, curved and shorter erections. The inner foreskin is a mucous membrane that contains cells that fight infection, and it's thought that an intact genital mucosa may be needed for future vaccines developed against STIs to be effective. The gliding action of the foreskin facilitates intromission or insertion of the penis, which is why circumcision increases penetration force by tenfold. That gliding action also reduces friction and thereby reduces vaginal dryness, which is why women are more likely to experience vaginal dryness with circumcised partners. So as I mentioned, the foreskin is highly erogenous. It is the most sensitive part of the penis, but indeed it is the most sensitive part of the male body. And that's because it contains those corpuscular receptors that are highly sensitive to fine touch, the Meissner's corpuscles, or vibration, so the Pacinian corpuscles, but others that sense things like stretch and other kinds of actions. This compares to free nerve endings, which cannot sense fine touch, but rather sense hot, cold, deep pressure and pain. So it's interesting to note that free nerve endings outnumber corpuscles in the head of the penis, the glands, by 10 to 1. And that explains why the head of the penis, the glans penis, is not very sensitive at all. In fact, it's the second least sensitive part of the body after the heel of the foot. And to put that another way, the threshold for touch in the head of the penis is actually the pain threshold. So it seems obvious, doesn't it, that if we remove the most sensitive part of the penis, in fact the most sensitive part of the male body, which is the foreskin, by circumcision, and we leave behind the least sensitive part of the penis and the second least sensitive part of the male body, the head of the penis, that we are obviously reducing penile sensitivity through circumcision. So why have we had mixed study results when people have looked into this? Well, the simple answer is that most studies have relied on subjective survey-based responses, and most men can't even correctly identify their circumcision status, which is surprising, but it's what we find. All right, so The best study that we have to date on penile sensitivity was conducted by Sorrells and colleagues from 2007. It's the best we have because it used an objective measure. They exerted a known amount of pressure. It recorded sensation from participants when it was felt, not what they think they remember feeling at some point in the past when answering a survey in the present. Physicians were involved in the study, which enabled the correct identification of the circumcision status of participants. And it took measurements from 19 different sites on the penis, which is far more than any other study that's looked into this. And in fact, of the few other quantitative sensory studies that have been performed, those that reported no reduction in penile sensitivity either did not bother to test the sensitivity of the foreskin, which is why they found no reduction, or they only tested a single site on the outer foreskin. And in fact, it was Bossio there that found the site they tested on the outer foreskin was more sensitive than the other sites, yet they counterintuitively concluded that despite their results, circumcision has no impact on penile sensitivity. It's a clear example of researcher expectation bias, which we see all the time in the literature on this subject. You can see here the diagram showing the intact penis up the top and circumcised up the bottom. This was taken from Sorrell's study. You can see the 19 sites that they tested there. The colour chart shows you the most sensitive parts in that magenta or red colour, going down to purple, blue, light blue, green, and yellow being the least sensitive. And what you can see is that in the intact penis at the top, the most sensitive part is the frenulum and the foreskin. And of course, all of that's removed in the circumcised penis, where the most sensitive part is the circumcision scar, where any remnant of the foreskin remains. It's also interesting to note that, as I mentioned, the head of the penis is the least sensitive there in the yellow, but the circumcised penis, it's less sensitive still, because the absence of the protective foreskin layer means that the head of the penis undergoes chafing and keratinization and more closely resembles skin than the mucous membrane that it actually is. I should also add that this is the best study we have, but it's not without its limitations. They did use a monofilament to exert pressure on a single point. So although the results here are quite stark, they do not really capture the sensation that's lost, because what they can't tell you is how all of those different corpuscular receptors that are all firing at the same time, for fine touch, for vibration, for stretch and other things, that dynamic sensation, there's no way to measure that other than to really feel it. All right, well, what about circumcision and erectile dysfunction here? There's two main points I'd like to make. The first is that there are clearly objective physical impacts to circumcision. It does reduce penile sensitivity, which, as we all know, is an important part of achieving and maintaining arousal. But there are also subjective psychological impacts, and whether circumcision is seen to enhance or diminish sexual pleasure and performance depends to some extent, and for many to a great extent, on whether or not individuals think it will. Okay, circumcision and premature ejaculation. Here, I need to tell you up front what the bulbocavernosus reflex is. It's a big word, but it's a reflex with an associated muscle of the same name, the bulbocavernosus muscle, and it's the rhythmic contraction of this muscle, along with some others, that facilitates ejaculation. It's very important for that. And that's why it's really interesting that we know that this reflex, this bulbocavernosus reflex, is clinically non-excitable in 73% of circumcised men, compared to just 8% of intact men. So circumcision would appear to dampen this reflex quite significantly. And that explains why some studies have shown that circumcised men have what's called a longer intravaginal latency time. It's a fancy way for saying they last longer in bed because of that diminished reflex and, of course, the diminished sensitivity. And yet, circumcised men are also more likely to experience premature ejaculation. And so that raises a really obvious and interesting question, which is, how can circumcision make it more difficult for some men and too easy for others to orgasm? And the answer is a combination of psychology and a history of erectile dysfunction. So some men with a history of ED report that their rapid ejaculation is due to concern they will lose their erection. All right, key takeaways. If you take away nothing else today from my presentation, I want you to know this. I want you to know that circumcision always removes the highly erogenous foreskin tissue and reduces penile sensitivity, that it often makes ejaculation more difficult by diminishing the bulbocavernosus reflex, that it sometimes results in erectile dysfunction due to reduced penile sensitivity and psychological impacts, and that while circumcision itself probably doesn't directly cause premature ejaculation, some circumcised men might experience this secondary to their erectile dysfunction. Well, what can you do about all of this? Well, I want you to question the normalisation of non-consensual, medically unnecessary male genital cutting. I want you to challenge cultural attitudes that perpetuate this harmful practice. And I want you to consider the circumcision status of your patients when they present for sexual dysfunction and mental harms. All right, my references will pop up. And I'll end by saying that that was a very quick overview of this subject, and I go into much more detail in chapter 2 of my book, The Final Cut, The Truth About Circumcision. And also I have to say that the loss of function, reduced penile sensitivity, and the potential for sexual dysfunction that is associated with male circumcision is clearly demonstrated by the medical evidence and yet rarely discussed in the medical settings in which it's promoted and performed, and we need to change that. Thank you. Quick reminder to keep using the app if you have questions, and we'll get to them at the end. But now it's my pleasure to introduce a recorded presentation from Leanne Morris, a UK psychotherapist who's just published a paper on the mental harms of male circumcision. So if we can get that up, we'll watch that now.
My name is Leanne Morris. I'm a UK psychotherapeutic counsellor and researcher, and today I'll be sharing findings from my qualitative study on a topic that is rarely addressed, yet deeply felt by those affected: the long-term mental health impact of non-therapeutic childhood penile circumcision. Grief is a universal human experience, but not all grief is treated equally. There are men living with deep, unresolved emotional pain from a procedure performed without their consent, a procedure often framed as benign, beneficial, or culturally significant. But for these men, it marked a rupture in their bodily autonomy and a wound in their identity. This is a form of disenfranchised grief, grief that is unacknowledged, invalidated, and silenced. This study was born out of what I perceive to be an ethical and clinical blind spot. Mental health practitioners are rarely trained to see non-consensual circumcision as a potential source of trauma. And yet I was hearing stories of distress, anger, betrayal of men whose pain had no social mirror. I wanted to understand these experiences more deeply and bring them into the therapeutic conversation. So I conducted 5 in-depth interviews with men who explicitly identified their circumcision as a source of long-term psychological harm. I used interpretive phenomenological analysis, approach that honours the personal, the emotional, and the existential. As you can see, 3 main themes emerge from the data. While each participant had a unique story, the emotional echoes were strikingly similar. The first being that grief disenfranchised. Every man described a profound sense of loss. This proved to be the core theme, but one they felt forbidden to express. And when they tried, they were mocked, dismissed, or simply told to get over it. Their grief was not just ignored, it was ridiculed. This led to a sense of shame, isolation, and an emotional shutdown. They learned early and painfully that their suffering would not be met with empathy. There was also a sense of relationships fractured. Many described lasting damage to their relationships with parents, particularly where consent had been given on their behalf. Some felt betrayed. Others described ruptured trust in medical systems. Intimate relationships were often shadowed by anxiety, embarrassment, or sexual pain. Emotional legacies that stretched far beyond childhood. There was a permanent psychological shift. Participants spoke of a deep rupture in their sense of bodily autonomy. Some described feeling violated. Others experienced long-term symptoms consistent with post-traumatic stress disorder. For all of them, circumcision was not a moment in time. It was a permanent psychological event, one that shaped how they saw themselves, their bodies, and their place in the world. So why does this matter for us as clinicians, as researchers, as people who care about mental health? Because right now, these men are not being heard. The frameworks we use to assess trauma often don't include their experience. The cultural scripts we've inherited dismiss their suffering before we've even asked what it feels like. And when they do find the courage to speak, they're often met not with empathy, but with invalidation. This is not just a clinical oversight, it's a form of structural inequality in psychological care. Therapeutic spaces must be safe enough to hold stories that challenge our cultural assumptions. We don't have to agree with a client's narrative in order to validate their pain. What we must do is listen without judgment, without defensiveness, without asking them to first justify the legitimacy of their grief. As practitioners, we must acknowledge these sufferings and create a validating, non-judgmental space that does not minimize lived experience. This research does not ask you to take a political position on circumcision. It asks you to take a human one, to understand that grief can be invisible and that silence is not the absence of pain, but often its companion. To recognise that if we truly want to offer trauma-informed care, we must be willing to acknowledge all trauma, even the kind that society prefers to ignore. For circumcision survivors, the wound is not just physical, it's existential. And the silence that surrounds it deepens the hurt. It's time we make space for this grief. It's time we offer support, not suspicion. It's time we say you are seen, your pain matters, and you are not alone. Thank you.
Well, it is now my pleasure to introduce Dr. Leif Thompson. Leif, over to you.
Okay, yeah, thanks. I'm Leif Thompson. I'm coming here from Alaska, and I was going to make the statement that I don't think anyone else is here from Alaska, but I met a woman last night that came from. She lives in Australia now, but so I can't make that claim. These are musk oxen. I used to be a guide, and I'd see those out in the wild, not in winter, usually in the summer. But they're in a defensive posture right now. They either form a line or a circle to defend their young. It actually ties in with the topic of my talk. Should all children be protected from non-consensual, non-therapeutic genital cutting, or just some? The title of my talk today is Different Bodies, Same Rights, a Case for Unity Against Childhood Genital Cutting. The talk presents the question, should all children be protected? My occupation is as a family physician. I'm now retired. so that I can advocate for children. So I've been retired for about 3 years and working in this space. I am not motivated only by what happens to children, but I'm also a victim of male genital cutting myself, and am motivated by that. My primary affiliation is with GALDEF, the Genital Autonomy Legal Defense and Education Fund, and I would like to announce that as of a few days ago, GALDEF is now a proud member organization of WAS, and we're very excited to add our voice to the passionate voices here that are advocating for sexual rights. I'm also affiliated with 15 Square, and as a peer support facilitator, I'll just have my, that's okay. Well, I work with 15 Square as a peer support facilitator and helping men who are suffering from circumcision harms. I also work with Brochim, a Jewish organization advocating for the inclusion of Jews and Jewish families that are choosing to opt out of circumcision. And I'm also work with doctors opposing circumcision. I'd like to thank Jonathan Meddings from the Darbon Institute for organizing this talk and herding us cats and keeping us in line. And I'd also like to thank WAS for having us here. I have no conflicts to disclose. Oh, there we go. So the first slide here is just embryologically, we all start the same. We develop with a genital tubercle as an embryo, and as we progress as a fetus, the tubercle will differentiate into male and female characteristics. At birth, it's differentiated, but the tissue is they're homologs. In this illustration, like most medical textbooks, the male prepuce is vastly underrepresented and may reinforce the perception that this tissue is insignificant. But the point here that I want to bring out is that male and female external genitals are homologs, and there's no anatomical basis for treating male and female cutting as ethically different based on anatomy. Both excise erogenous genital tissue from the same origin. So I'm going to move on to other variations of sex characteristics. We have the male and the female, but there's also a group that has variations of sex characteristics. So in many ways, it's useful to think of sexual genital phenotypes as being a spectrum rather than being two ends of the pole. And I'm going to use this example as a way of navigating through our history of selective protections for children from genital cutting. So throughout most of history, children were seen as property of their parents. They were not seen to have their own individual rights. This is, within patriarchal systems, this is very similar to past perceptions that women were property of their husbands. There's a power differential that happens, and children were seen to not have power and not have choice. This started to change in the 70s to the 90s with the feminism. There was a perception that the cutting of genitals without consent is a violation of human rights. The cutting of female genitals were seen as mutilation, reflecting these cultural changes. There began to be selective laws enacted to protect girls from childhood genital cutting selectively, but the other children were not yet considered for protections. I'll just keep moving on here. Increasingly, there's been a discussion over the rights of those born with genital variations. Malta was the first to ban gender normalizing surgeries on these children in 2015. Since then, Germany, Iceland, Portugal, and some other regions have added protections for intersex children from medically unnecessary surgeries. And I'd add the Australian Capital Territory passed world-leading legislation in this area in 2023. So now as we're moving across the spectrum, we're left with the final area of male children born with phenotypically male genitals. I say it that way, and I have to correct myself, this because we don't know when a child's born if their gender is going to match their phenotypical genitals. So in contrast, Western society has been very reluctant to include protections for children born with phenotypically male genitals. Male genital cutting is framed as a parent's right, and the boy's right to bodily autonomy is not considered, as it would be if we were discussing female genital cutting. This framework places greater value on the rights of cultures, religions, and the parents over the rights of boys to have a say of what's done to their own bodies. Even within sex-positive organizations like WAS, that advocate for sexual rights, justice, and pleasure based on equality, even here we find it hard to discuss male genital cutting within the context of individual rights and within the context of individual consent. Why might that be? One reason could be that all of us come from cultures who practice male genital cutting to varying degrees. Many men here at WAS 2025 have been subjected to genital cutting themselves as infants or children. Some parents here may have subjected their sons to male genital cutting, and some here may have even performed male genital cutting themselves. I'm not saying this to cast blame, far from it. Instead, I want to bring attention with empathy on how difficult it is to face this discussion, even here. Objectivity is elusive when we are absorbed in our own biases and our own defensiveness. It's not easy to engage critically in human rights discussions when it brings a critical light on our own practices. While I'm advocating for this discussion, I want to point out that this discussion is inevitable. As you saw it progress over the page, we are closing in on the last area of non-voluntary, non-medically necessary childhood genital cutting. This is an inevitable conversation that is going to happen. Regardless of how we feel, future discussions on bodily autonomy will include boys just as surely as the sun will rise tomorrow. The progression of our discussion of sexual rights, justice, and pleasure must logically go forward in the direction to include the rights of boys. Yes, this will be uncomfortable, but it's also unavoidable. I would like to switch gears for a bit and explain why this issue may have not grabbed your attention in the past and why the general perception is that cutting off erogenous tissue from a male is not harmful. I've heard many times the statement, well, I've never heard men complain. There is a dialogue going back and forth between society and individual men who are suffering from male genital cutting. I call this the cycle of silence, which leads to the prevalence paradox. So we have cultures where male genital cutting is normalized and expected. That is projected when men feel harmed by being involuntarily cut. They experience ridicule, dismissal, rejection when they're revealing their experiences of harm. Through that, they fear stigma. They fear social isolation, and they fear being gaslighted. They avoid expressing their experience of harm. This leads to the societal perception of, well, men don't complain. So essentially what happens is we have a system where men who complain are seen as being abnormal. In other words, something is wrong with them as opposed to what was done to them. To break the cycle of silence, we need two things if we want to understand male genital cutting harms. First, society needs to learn how to listen. And the second is that men with lived experience must be empowered to speak in a safe and supportive environment over what their experiences are. I'm going to go into a little bit of detail on our terminology, and then I'll close fairly soon here. I taught a class twice now, and the title of my class was Genital Cutting, Enhancement or Mutilation, a very deliberate use of terminology here. In these lectures, I explore a wide variety of genital modifications practiced around the world, what people choose to do for themselves, but more importantly, what people choose to do to the genitals of others, particularly children. My title very deliberately encompasses the neutral, genital cutting, which is descriptive, but also use the expressions of positive and negative values of enhancement or mutilation. The values we place on genital alteration are by nature subjective, not objective. So the difference between enhancement and mutilation depends on who is making the judgment. The person who lives with the results of non-consensually, medically unnecessary genital alterations is the one whose judgment should be most heard. I believe that our discussion of genital cutting practices is hampered when we believe that our value judgments are objective. They are not. There are cultural reasons behind this. Each of the valued terms we commonly use, circumcision or female genital mutilation, there's a historical reason for those. But my approach is to remain on the center category. You've heard throughout my lecture I'm talking about male genital cutting or childhood genital cutting to be neutral. But my approach is also to try to focus on the bottom category of child genital cutting to emphasize the embryological homologs that we are all one. Basically, with variation. And we need to start considering child genital cutting as one issue with varying facets rather than three separate issues affecting different populations. I want to leave with just a few more thoughts and then I'll close because I think I'm going over, sorry. We could forward on. The suffering from childhood genital cutting is not gendered. Child genital cutting is traumatic regardless of the genital morphology. All cultures that practice female genital cutting also practice male genital cutting, yet we use the term gender-based violence applied to female genital cutting, and I believe that's an inappropriate term when their brothers are being held down and cut right alongside. This is a violent act against children, and the power dynamic is not male over female. The power dynamic is adult over child, and we forget that boys are not men in waiting, representing the gender dynamic. Boys are children, just like girls. Worldwide, the prevalence of male genital cutting is far, far greater than the prevalence of female genital cutting and intersex genital cutting, but all cause suffering and harm. It offends the UN Declaration on the Rights of the Child and the Universal Declaration of Human Rights not to protect all children. Every child is vulnerable. Every child deserves protection equally. I'm going to just close on this last thought here that envisions a future. I want to leave you with this. Every child is born with a beautiful, unique, and very private flower of their very own. This flower has the capacity to bring them joy, pleasure, and connection to others, and even to themselves, giving them a sense of identity. It's almost magically a source of creation and the ushering in of new life. This flower is not shameful, nor is it trivial. This flower is sacred. A child's sacred flower is theirs alone, to later choose to share or not to share, to change or keep as it is, or even to decorate however they want when they are ready to do so. Every child, every human has the birthright to consent, to be able to say, my body, my choice. It does not matter if the shape of the flower is a penis or a vulva or something more and rare and special. What truly matters is that it's the child's private flower and not anyone else's. Our duty is to protect these children and their private sacred flowers from anyone that would claim them for their own purposes and violate what is not theirs. My vision is for a world where all children can grow up free from the violence to their bodies and to live an open future to choose what is done to their bodies regardless of the shape of the genitals that they were born with. Thank you.
Thank you, everyone. We're now moving to the panel discussion component. Just a reminder to use the app to ask any questions that you have, and we'll hopefully have time for some at the end. We're all going to be mindful of time, and I'm going to reintroduce myself. It's not because I think you've all got short-term memory loss, but we are recording this session, and this will be published separately. So, all right, we're all good to go. The way this will work is I'll speak to each person on the panel separately, and I'll introduce them as we go. All right, well, hello there, I'm Jonathan Meddings, the chair of the Darbon Institute and author of The Final Cut, The Truth About Circumcision, and it's my pleasure to be moderating this panel discussion. I want to start with Jason Simmons, who is an ambassador for the Darbon Institute and a circumcision survivor who is bravely sharing his story here for the first time. Jace, how did you first become aware of circumcision harms?
Good question. My earliest memory of becoming aware of this issue was I was 3 or 4. I saw the aftermath of my brother's mutilation, my cousin's mutilation, and something just didn't seem right about that. Instinctively, I would pull the skin over my glands, not even knowing what an intact penis looked like at that stage. It just didn't seem right at the time. And then so fast forward to my early 20s, and I am out in the world and start to see advertisements for vasectomies. And I start to have a body reaction to this, and I start to have a fight or flight reaction. I start to get angry, and I don't understand why. And that was curious. And then 7 years ago now, I had a groin injury, and I had to go to the doctors and be examined, and I ended up in a panic attack. And that process of being examined over several occasions, the panic attacks got worse, and then they didn't stop for 6 years. And I ended up almost ending my life, and I'm lucky to be here. Yeah.
Well, thank you for sharing that, Jason. How hard was it to find trauma-informed support services when you went looking?
Yeah, it's not easy, and it's it's something that I've heard other people, even at this Congress, talk about, is seeking help is difficult. It took me 3 months to be able to get to a psychologist. That was just their waiting list. And when I did, it took me another 2 months to get my second appointment. So I was in a really bad place, and it took me a long time to get help. When I did, the therapist, I love him to bits, he's a fantastic fellow, but he went looking for another reason why I was experiencing PTSD. He didn't believe me that this was an issue, and still hasn't validated that this is, that the reason that I was having a body reaction and a body memory was because of male genital mutilation. At my lowest point, he said to me, "Jace, I don't know how to help you." And I sent him to the Darbon Institute website, and 15 Square, who have also been mentioned today, referred him to their website, and he started to understand this issue. Our relationship as a therapeutic relationship continued for a while, and it kept me alive, but it didn't cure me. I went to the Amazon jungle and used psychedelics in Peru as well, and I came home from there finally with some joy and feeling positive about life again. And the breakthrough for me in getting care was seeking somatic therapy, which I'm doing every week, and that has been a huge breakthrough for me.
What would you like to see changed?
For me, there's three things. The first thing is what we've all sort of spoken about already, and that is equal protection of every child. It doesn't matter what their genitals look like. We all deserve the same protection. It's just as simple as that. Just as simple as that. And the second thing is that Medicare helped fund my mutilation. So Medicare should be funding my journey to wellness. I've spent a house deposit staying alive. I've spent a house deposit trying to free myself from this. And I believe that there should be an investment from the federal government on helping men like myself and those with a penis to get well. And if that involves psychological services or physical interventions or like regenerative medicine, foreskin restoration, those sorts of things should be supported by the federal government. The third thing, and probably the most important for me, is if you take nothing away from today, from my heart to your heart as human beings, I want you to see us, and I want you to hear us, and I want you to acknowledge the harm from this and our pain. Yeah? And I want you to stand with us and fight. Because the World Health Organization is pushing this again. And it's coming to a country near you. So stand with us and fight, because we stand with you as well. That's all. Yeah.
Thank you. Thank you, Jason. That was incredibly moving. I want to turn now to Dr. Leif Thompson, a physician from Alaska who runs a peer support service for 15 Square, a men's charity in the UK. And quickly, could you tell us, Leif, a bit about that service?
15 Square has a direction that they're trying to not only inform the public about male genital cutting so that better policy can and better education for decisions around this can happen, but they're also really wanting to create and foster ways to help treat men that are suffering from problems related to that. The peer support is an online support group that meets once a week, and it's international. We actually have roving times to accommodate how the globe has different time zones. And it's a place to gather, have support, not feel that we have to explain ourselves to be validated, and gain strength from camaraderie. So that's basically what this service is peer support. There needs to be, I think, I feel inadequate as a peer support leader without having the level of training that I think I might need to do this effectively, but this is a funding issue. There's limited funds, and being trained takes money. But I do want to just report one thing from the groups. There's a lot of deep emotional things that are shared, and it's a safe environment. But one of the things that's almost universal, I would almost say it is universal, is that everyone who sought therapy has been rejected. Their issue has been rejected by their therapists on the first go around, as is my case. And I was lucky. My second therapist was spot on. It was really good. And for me, narrative therapy was the best for me. But this is an almost universal experience now. We really need, if there's psychologists out there and sex therapists out there, to get interested in this topic and help to build something new that's helpful. There's a real need.
Thanks, Leif. Would you also be able to share your story of circumcision harms, and how has it impacted your Jewish identity in particular?
Oh, yeah. I was circumcised in part, well, the main reason why I was circumcised because I was born in the United States, and when I was born in 1963, everybody was circumcised. And just to give you an idea, in 1963, preventing masturbation was one of the reasons to prevent circumcision. But my mother is Jewish. My father is not. That's why Leif Thompson's not a very Jewish-sounding name, but it's I am Jewish. And my mom thought, well, we're not religiously Jewish, but if we do the circumcision now, then he doesn't have to get circumcised later. Let's do him the favor. So that's the Jewish part of my being cut. I found out at age 13, but I knew I was not supposed to talk about this. I didn't tell another soul that I was distressed about this until about 27, when I learned that there were other people, and it was like an emotional breakdown at that point. As far as the Jewish identity, I just want to make, there was a comment, I think on day one of one of the speakers was saying, talking about the cutting off of the foreskin as being identity forming. It's identity forming for the person deciding the cut. For the person being cut, it can be identity forming, but it can also be identity destroying. When I respect the Jewish culture, I am of the Jewish culture, but if I sit down to a Shabbat, I feel mild nausea. It's sitting in the house of the abuser. And for my case, my biggest obstacle with feeling Jewish is what was done to me under the auspices of Jewish culture. That changed for me recently when I learned of this organization called Bruchim. Bruchim is an organization trying to foster spaces for the discussion about circumcision, and also fostering spaces for belonging for families and boys and men who are choosing not to be circumcised. So this change is happening within Jewish culture. It's not all, if somebody's against circumcision, you can't assume that it's anti-Semitic or coming from outside, because probably one of the biggest groups of people that are trying to work for genital autonomy is Jewish people. And, the other thing, last thing, is that there is a lot of men on my peer support groups that have a similar experience. They feel like they can't be Jewish because of what was done to them.
Thanks for sharing that, Leif. I want to turn now to Tim Arkell, who is the Executive Officer of the Darbon Institute. Tim, could you start by telling us a bit about Darbon?
Sure. The Darbon Institute is a successor, I guess, of an organisation created by Paul Mason, the late Paul Mason. Paul was a Brisbane-based barrister who spent the whole of his life advocating for children in this space, and he was a world force, and he passed away in 2018 suddenly, and the organisation he created was called the Australasian Institute for Genital Autonomy. It was an incorporated association incorporated in Queensland. Without telling you how I came on, because we're running out of time, I was asked to become the secretary of that incorporated association because I'm a resident of Queensland. I'm also a lawyer here in Queensland. I'm a solicitor. For those of you from overseas, there are two branches of our legal profession in Australia. You are either a solicitor, like a GP, or you're a barrister, like a specialist. So I came on to the organisation as the secretary and trying to fill some very big shoes as a human rights lawyer.
Thanks, Tim. That's a really great summary of the history. Could you tell us a bit more about the activities of Darbon, the program areas?
Sure. There are a number of key areas that we're working on at present. Firstly, we're creating educational resources and programs for the public and for the healthcare profession to outline and point out to them the harms of non-consensual, medically unnecessary genital cutting. Parents need information to understand the moral implications and the socio-cultural triggers that lead them to seek circumcision for their sons, especially so given the rate of routine infant circumcision in Australia is now below 8%. And healthcare professionals need to understand that doing non-consensual, medically unnecessary male circumcision on children that are too young to personally consent or understand what is occurring to their bodies is a breach of the Hippocratic Oath, primum non nocere. Now, there's a link to a journal article in the on the Darbon Institute website. If you go to the resources section and find the professionals' information, there's a link to a journal article, and I won't give you the name of the whole journal article, but it starts with genital modifications in prepubescent minors. And it will talk to you about the ethical problem of healthcare professionals doing this procedure on children. The second is that we're empowering survivors to share their lived experience in a safe and supportive environment. And you've heard from two fellows today, and you can hear more by going onto the 15 Square website, where by providing a safe and supportive environment, we're hoping that it collectively forges change and leads to different outcomes for future generations of girls and boys and the men and women that they will become. And thirdly, we're establishing trauma-informed support services. And I'm buoyed by the number of people that I've been able to speak to over the course of these last couple of days in trying to find appropriate trauma-informed counsellors. Ron Goldman, in a book written in the late 90s, outlined the harms of circumcision in a book called Circumcision, the Hidden Trauma. If you haven't read it, it's an informed source. We've heard today about the disenfranchisement felt by many men when seeking trauma-based therapies. and it's been noted in the literature, and Leanne spoke about it today. You can find a link to Leanne's study on the Darbon Institute website, www.darboninstitute.org. And the Darbon Institute receives many inquiries from men affected by this procedure. And as I said, we're looking to establish proper trauma-informed resources so that we can do referrals to properly train people.
Thanks, Tim. We are fast running out of time, and I do want to leave time for a couple questions at the end, but you are a lawyer, so we can't miss asking you what kind of liability practitioners who perform this procedure are exposing themselves to.
Sure, look, I'll speed up. Firstly, as a solicitor in this state, I am subject to ethical considerations. As an officer of the Supreme Court of Queensland, in my personal life, I am held to a higher ethical standard than the ordinary person in the street, okay? And it should be no different for a healthcare professional when people are going, and the unique position that they're placed in, when people are going to them seeking their advice and their care. Under the guidelines for medical practitioners who perform cosmetic, medical and surgical procedures, healthcare professionals are required to follow any relevant legislation in the jurisdiction in which they are operating, so hence here in Queensland. And the guidelines define major cosmetic, medical and surgical procedure as anything that involves a cutting beneath the skin. Now, it doesn't take you to be a lawyer or a rocket science expert to know that circumcision excises healthy tissue from the male penis. It involves cutting beneath the skin. It is a major surgical procedure. And further, the guidelines assume that you have obtained the personal consent of the patient undergoing the treatment. And when parents consent to this, that's not the person undergoing the treatment. Additionally, for healthcare professionals in Queensland, there is a prohibition on cosmetic surgery on minors. That is contained in a piece of legislation created by Anna Bligh back in the days when we had the lovely Anna Bligh as our Premier. And healthcare legislation, restriction on the use of cosmetic surgery for children and another measure, I don't know what that one is, 2008. And a failure to observe the guidelines and the prohibitions and the requirements in the Act could leave a healthcare practitioner not covered by their professional indemnity insurer.
Yeah, that's great, Tim. And I'd probably just add to that, we've got criminal laws as well against things like serious and grievous bodily injury. Cutting off healthy tissue from someone who can't consent would certainly seem to meet that test. And I think there's a lot of practitioners who can count their lucky stars there hasn't been a test case. Because we did in Queensland while we're here, we had I think it was a 1993 paper by the Queensland Law Reform Commission, which said it would appear to meet that charge. All right, well, can we give a round of applause for our panellists? We have 1 minute left for a great many questions. So I'm going to say you can certainly speak to all of our panel members today during the break, but I will quickly run through a couple. One questioner asks, what would you say to new or expecting parents who want to circumcise either due to religion or what they believe it being healthier or looks better? A short answer would be please don't. Allow your child to grow up and decide for themselves if they want to be a part of that religion through that practice, if they want to express their religious beliefs that way. We've got a lot of other questions we can't get to, but a quick note about Gary Dowsett is asking me, Professor Dowsett, if I can let you all know that there will be a call for papers from the Culture, Health and Sexuality Journal on VMMC and HIV. So keep an eye out for that one and get in your abstracts. All right, well, that's bang on 12. So I can hear it buzzing. So I'm going to keep my promise and keep to time. Thank you, everyone. It's great to see a packed room.